Now stick your chin forward and do it again. What should be happening there is that contact point moves forwards. Yeah?
I had surgery, so it's
More mental.
It depends on how far you can retract and so on. It also depends on your stand and your bite. But basically this will underswing the jaw, so you're going to do this. It doesn't, and if you keep your head in the middle, tap again, and then turn your head to the right and tap again, you'll find that you start coming down on one side rather than the other side. And that's usually the side you turn to. So changing your head position changes the way you bite. Which for most people is not a big deal, because most people at rest, their teeth are not in contact. Now people who over-close do contact their teeth. So if you're over-closing, which in itself is probably recoverable and not a big deal, but if you now combine that with a fixed head position where you're getting more contact, then you can start getting problems with this. Now this is the whole thing with chronic TMJ problems. There are predispositions, there are triggers, and there are causes. With chronic stuff, the tendency is the cause is no longer a big issue. So your predisposition, the way the dentists look at this, is your bite. Now, they also screw it up, as we talked about this yesterday, they'll also screw it up sometimes and say this is the cause of it. It isn't. We've all got malocclusion. There is very few people out there who doesn't have malocclusion, like everybody's got lousy posture. It's a predisposition that isn't always and isn't usually potentiated as far as pain is concerned. Now, how many of you get clicking in the jaw? 1, 2, 3. All right, so if it's 3 of you, that's a third of you get clicking in the jaw. That's 33% of this little sample. This is a high number. It's like the patella. How many of you get clicking behind the knee when you stand up each time? It's the same type of thing. These are fairly delicately fired systems and they break down, but they don't become symptomatic typically. There's your predisposition. Now, what they don't usually talk about is other predispositions, and it may not be, but the neck is definitely one. Where your neck is positioned, the way it moves and everything else. But the neck may also be the trigger. So your predisposition is that. Now, on top of everything else, the other part of this is stress. And they find most people with chronic TMJ problems also have chronic stress problems. And the link seems to be teeth grinding. And teeth grinding is I was going to say it's a way of lessening stress. Actually, you don't do it deliberately, so it's really not. It's a result of too much stress. You tend to grind your teeth, and it occurs at night. Now, the problem is, if you do have malocclusion, and your teeth are in contact, obviously, when you're grinding your teeth, what should happen, ideally, is your teeth should slide across each other, and it does relieve stress. You're actually taking all that inbuilt stress and changing it into kinetic movement. It releases and stuff. Now, the trouble is, if your teeth lock, so your teeth can't slide over each other, the sliding now occurs at the TMJ. So you start stressing out the TMJ, start wearing it away. But it's usually with chronic TMJ problems, there's this predisposition, the trigger, and the stress go together. Now the other thing that's interesting was there was a study done with fibromyalgia. And they studied people where the cause of the fibromyalgia, the presenting complaint that was then followed by fibromyalgia, was TMJ pain. So these people developed TMJ pain and then developed fibromyalgia basically. They had all the criteria for fibromyalgia for the diagnosis. They took these people off of everything, medication, exercises, icing, everything. They took them off everything, psychological counselling, everything. And they put them on a vestibular program, and they got better. They didn't teach them how to manage their pain. Their pain got better. Their function improved, the tender points went down, their general level of pain went down. They got better. And their argument was that with this particular group in fibromyalgia patients, they wouldn't extend it past it, but for this group, they reckon that what they were dealing with were vestibular problems. And all these tender points were points on hypertonic muscle because of the vestibular spinal screw-up. So by putting them through 6 or 8 weeks of vestibular therapy, they actually got the vestibular system under control, the muscle tone went down, and the pain went away. So,
Was that like VOR vestibular stuff?
no, well, I don't know, they just put them on vestibular therapy. So whatever it is they're doing. This is not, obviously not manipulating the boost bodies, but this is like rehab for neurological problems. Neurological vestibular problems.
That subset was fibromyalgia with TMJ.
TMJ was the presenting complaint that then developed into fibromyalgia. So how are these mixed? Well, probably the main link between the TMJ and the neck and head pain is the trigeminal or the cervico-trigeminal system. Trigeminal nerve's really interesting. It's responsible for sensation from the spinal structures in the neck. Pretty much everything from the posterior wall of the pharynx back, including the paraspinal muscles for proprioception and so on, and for pain. It doesn't innervate the skin of the neck, but it does all of that. So it's responsible for pain, proprioception, and so on.
Of the neck?
Of the neck. About midway up, C3 and up, something like that. In the head, it's responsible for all sensation except for the special sensations: taste, smell, vision, and hearing. So it innervates the blood vessels of the brain, the dura mater, everything that's got nerves to them. The eyes themselves, the pupillary muscles, intra and extraocular muscles for proprioception again. It also supplies the muscles of mastication, modally. It supplies some of the inner ear muscles. As a motor function, sensorbellar palatine in particular. So this becomes the link between everything. Now, if I want to balance my head, all right, I want to stand upright with my head balanced, I do it in a number of ways. One is the semicircular canals and the static labyrinth. So basically, the vestibular portion of the vestibular cochlear apparatus, plus the nerves going away from it and going to the cerebellum and everything else. So the vestibular nuclei, the vestibular apparatus, the cerebellum, are all involved in the reflexive control of the head. Your vision is as well. You balance your head by your vision. The upper cervical spine is also part of the balancing act. And your jaw. And what your jaw does basically is it acts as a leveler. So what the system tries to do is keep the plane of your jaw. If you used to bite a piece of cardboard between your teeth, it will try and keep that cardboard perpendicular to the line of gravity. If I'm going over that way, it'll do that to bring this back. Yeah. Now all of that has to be integrated, and it's integrated in the brainstem, and obviously also in the cerebellum. And there's connections. So it's not just, well, we said the neck. In the neck, we're talking about the anterior and posterior cervical suboccipital muscles. Now these muscles are interesting. They are roughly orientated in the same planes as are the extraocular muscles of the eyes. And both of them are orientated in roughly the same planes as the semicircular canals of the inner ear. So they're obviously related to each other in function. The suboccipital muscles also have more spindle receptors per fibre than any other muscles in the body. So their function is not to turn the head. Their function is to monitor what's happening to your head. They're much more receptive than they are motor. very sensitive sensory tools. And then you've got the big muscles, which is why these are cranial muscles, sternomastoid and trapezius. So all of this can be integrated very, very quickly inside the brainstem. It doesn't have to travel miles to get out and back in again. This feedback's going on all the time. Now imagine what happens if I have, we can look at this in different ways, let's look at it from the jaw perspective. I have a joint problem. One of the TMJs is jammed up and the jaw now is sitting like that. Okay? So a piece of cardboard held in my teeth, put it like that. But what my brain is saying, what this integrating system is saying, it's not the jaw that's buggered up, it's the head that's buggered up. So now, instead of the jaw being like that, my system figures it's the head being like that. So what it does is correct it. So it will bring the head back, try and correct the apparent anomaly here. So what you do is you move, particularly in the craniovertebral joints, you move some of the joints closer to their end range and some of them further away from their end range. The muscles are also getting misreading. And what you felt was, this misreading is almost certainly going to lead to long-term effects if it's there for long enough. And this can be inhibition again, simply because they're not contracting properly and not being stretched properly. So the amount of proprioception coming in and out of them isn't as much as it should be. So you may get reflex inhibition. But the joints are going to take some damage, especially if I'm involved in activities that require rapid movements and full range movements. So it's full range in the direction where you already move towards, so you can start damaging those joints. The combination of that increased positioning in the range and less competent muscles lends itself to damage to these joints. So you can see how, at least theoretically, TMJ dysfunctions can damage particularly the upper cervical spine. By the same token, the craniovertebral joints are jammed up and it changes the position of the head. And you see what happens to the TMJ when it happens. Your bite plane changes, your occlusion changes. And again, potentially, you've got the possibility now, you've got extra malocclusion on a joint that's going to be damaged. The craniovertebral joints are causing TMJ problems. All of which can create headaches because of the trigeminal nucleus. This all projects through the trigeminal nucleus. You can get some really weird symptoms. You can get ear symptoms, stuffiness in the ear because you get hypertonus of tensor belli palatini that closes down the eustachian tube.
How long does that usually take to fix? Because we have a patient like that. She's had it for several months.
If you get rid of the tone, then the stuff feeling in the ear,
Yeah.
that's what it's coming from. You get rid of the tone, then the stuff feeling should go away, at least temporarily.
Improve the tone and stuff.
In that case, it's not that. You've got to remember it goes the other way. If she's got a problem with the eustachian tube, it's going to feed into the trigeminal nucleus, and then that can create problems in the neck or wherever you're treating. This stuff feeds in both directions. Your problem's going to be cause and effect. So you get all this going on, and this is the stuff that can be a problem with these complex headache patients, especially when you get widespread symptoms, ear symptoms and so on. And it's well worth looking at all this. Now, I said this to Dave, I don't want to get into a lot of TMJ treatment here. The TMJ, I was involved in a lawsuit years ago, and my involvement was reading through the case notes. There was a PT who was treating a post-surgical TMJ patient. She's doing rhythmic stabilisation, so she's got her hand in this patient's mouth and they hold relaxed. Anyway, somewhere or another they got their wires crossed, and the patient thought she said relax, she thought she said contract, just ripped through the surgery. This stuff is not nice stuff. I think if you're going to treat TMJ patients, you really do need to do a dedicated course to it. So looking at it from this perspective is perfectly reasonable. The less often you put your hands in somebody's mouth, the better. All right, for all sorts of reasons. The main one being, though, this is an easy system to screw up. It's very easy. If you can avoid it, do so.
So if you find a hypomobile TMJ, you're again, she's doing grade 3 or grade 4 mobilization in the plane.
I'd rather not do it. I'd rather find somebody who's dealing with TMJ problems on a regular basis. Get to do this. I really would. Because it isn't just a joint. You've got to look at the occlusion, tooth structure. There's a whole bunch of stuff involved in this that doing 2 hours talk in a class ain't going to cover for it. I would screw them. If you've got somebody down there who's dealing with TMJ, then you can do it. 15 years ago, 20 years ago, you could not swing a cat for hitting a TMJ course. Do you remember this? I mean, they were all over the place. Rockabada was the in thing then. I mean, there were TMJ classes everywhere. When was the last TMJ class you saw advertised? People don't like them. Patients are a pain in the arse. They never seem to get better. You're dealing with dentists as well, so it's another medical profession you've got to deal with. It's a pain in the arse, this stuff. It really is.
Not many dentists are good.
No, they don't want to do it. They don't want to do it. And most of these patients, well, I say most of them, chronic TMJ patients tend to be flaky, and they tend to be chronic pain syndrome type personalities. They're moving down that road anyway. If that's your practice, then good luck, but you do need to go and do a class on this, a proper class on this. Because now you're going to look at sticking stuff in their mouth as well. So you've got that to contend with. But let's look at it from our perspective. You're not going to get involved in TMJ as a specialty. You are going to encounter these patients from time to time. And there's stuff that you really want to know something about. First off, if you've got a patient who is going to have TMJ work done by the dentist and they're going to have a splint put in, it is more than worthwhile looking at their neck before they do that. One of the worst things you can do is they go and get a splint put in, they come out, you manipulate their neck, and all of a sudden the splint doesn't fit anymore. And it doesn't take much for the TMJ to become extremely painful when this happens. I don't know if any of you have come across this in family members or patients. You have a filling done, and they don't take the filling down enough. I mean, we're looking at millimetre here or so, and the amount of pain that can produce is agonising. All it needs is another 30 seconds of scraping, and it's done. It doesn't take much for this joint to flare up. You've got to be real careful with this. So I think what we'll do is we'll look to see evidence that the TMJ is involved, which isn't always about pain. As we said, a lot of this stuff is painless. We're looking for quiet culprits. So we'll look at evidence that the TMJ may be involved. And some of this stuff we've already looked at from a different perspective. You palpated the suboccipital muscles, the posterior suboccipital muscles, and you palpated for time. And you found stuff. Typically, what you'll find is one level affected. Now, there is some sliding to the second level, obviously, because you haven't got that same constriction that the thoracolumbar fascia gives in the spine, so it does spread over a bit. But one of those levels is bang, that hurts you on it. Is this what you found? Yes, anyone is feeling for this. And often there's a bit on one side and changes on the other side, either hypertonus or hypotonus, yeah? You have a TMJ problem, and it's all one-sided, and it's 2 levels. And this is hypertonicity. Just a lump sticking out the back of the head. So that's your first clue. The other clue is, if you look at their face, now you do this with the patient upside down. Let's see if we can find one. Usually you can, because it's such a common thing. What's the lowest split we've got? This one. That one. Let me have somebody land on.